Good afternoon and welcome to today's ORN webinar, Developing the Peer Workforce Through Training, Internships, and Placement. My name is Len Statham. I am with the New York Association of Psychiatric Rehabilitation Services, and I will serve as your moderator today. The three speakers that we have today are all prominent national recovery experts in their own right, and they have a ton of contributions to local communities and the global recovery effort, and we're lucky to have them. During webinars, we all have this tendency to multitask, to be doing other things, and I'm going to ask that you put down whatever you're doing now and just really give your full attention to this event. It's an important topic, and I'm sure that you're going to find these speakers worth the time. Just a couple of housekeeping items. We're going to have participant phone lines muted throughout the presentation. And then when we enter the Q&A period, the phones will be unmuted. But we will tackle the queued questions submitted in the chat box. We'll be looking at them first. So if you have any questions, and as you're listening to presenters, just feel free to put them in the chat box, and we'll definitely get to them during our Q&A session. SAMHSA's State Targeted Response TA Assistance, STR-TA grant, created the Opioid Response Network to assist STR grantees, individuals, and other organizations by providing the resources and technical assistance they need locally to address this crisis. The TA is available to support the evidence-based prevention, treatment, and recovery of opioid use disorders. Next. So the ORN provides local experience consultants in prevention, treatment, and recovery to communities and organizations to help address this crisis. The ORN accepts requests for education and training, and each state or territory has a designated team led by a regional technology transfer specialist, or a TTS, who is an expert in implementing evidence-based practices. To ask questions or submit TA assistance, all you have to do is visit the www.opioidresponsenetwork.org or email orn@aaap.org, or simply call 401-270-5900. All right, I want to introduce you to our experts today. We have three distinct individuals that each bring a different component of the topic to you. We're going to start with Yvette A. Thomas. She is an Employment Support Services Coordinator at Unity Recovery in Pennsylvania and has been living recovery for the past 7 years. And while struggling to move on with life after addiction, she discovered peer support and immediately began to help in that field and helping people to recover using her own life experience. She started working out in homeless shelters and drug and alcohol recovery centers as a peer support specialist, and now finds herself as a coordinator. George Braucht, over 30 years of teaching psychology and delivering services that help organizations translate what works and outcome research into empirically supported outcomes and interpersonal skills and program practices and organizational policies. He is currently has his own consulting practice, Works, that helps organizations apply science to practice. And he is the co-founder of Certified Addiction Recovery Empowerment Specialist CARES, and with the Georgia Council on Substance Use, and the Forensic Peer Mentor Ready for Reentry Training with Georgia Mental Health Consumer Network. And last but not least, we have Lisa Conlan Lewis. Lisa is the Executive Director of Parent Support Network of Rhode Island, and she's been a state and national consultant of peer service delivery for over 26 years. Lisa leads the state certified peer recovery specialist workforce development program and delivers integrated substance use and mental health peer recovery services. She brings experience as a parent of children and adults with behavioral health needs and as a person in long-term recovery. So I'd like to bring up Yvette. Well, first, let me share our training objectives. There's really 4 of them today. We're going to review how peer support workers assist people to start and sustain long-term recovery. We're going to describe what competencies are covered in peer support trainings and certification programs. We're going to identify ways to offer paid and unpaid internship opportunities for newly trained peers so that they can practice their skills and build their confidence. And finally, we're going to discuss the value of partnerships between RCOs and other organizations to provide trained peer support specialists in various settings. And with that, I'm going to turn it over to Yvette. Yvette? Yvette, I'm going to have you unmute yourself.
In my experience as a certified peer specialist. My name, as Lynn mentioned, is Yvette. I'm a person of recovery. I'm a certified peer specialist. And currently I'm the Employment Support Services Coordinator at Unity Recovery in Philadelphia, Pennsylvania. Slide 2, please. I became a certified peer specialist in 2015 after leaving a 20-plus career in insurance, customer service, and sales. The career change was highly due to my recovery and the fact that I wanted to feel good about what I did for a living. And I wanted my work to be conducive with my recovery and my new way of life. Once I was introduced to peer support, I knew it was for me, and I jumped in with both feet. I got my certification and subsequent training from Mental Health Association, which is now Mental Health Partnerships in Pennsylvania. I was very lucky in that I knew some people in the peer support network, and I found work rather quickly after the training was complete. I went into the interview knowing that I had strong communication skills, and I used those skills to sell myself as somebody who was ready and willing to get started working in the field. Once I was hired, I made sure to sign up for every training offered. There's always more to know, and I wanted to know all of it, and I still do. And one of my favorite sayings is never stop learning. Next slide, please. Thank you. There have been a lot of positive experiences since I started working as a peer specialist. I've, of course, gained experience in the field, so I've learned a lot. Since I was coming from a whole different business sector, I was glad to gain any experience that I could come across to help me with this current career path. There were many learning opportunities amongst the way. I was familiar with my recovery process, but not with those of others, and the many different struggles that so many were living with every day. I wanted to help. So I started to work on building a network. I began building relationships with others in the recovery community and finding as much info as I could about local resources for my participants. I learned that in customer service that it's easy and important to know where everything is to find it quickly. When you're on a call, you don't have time to go look for stuff. So I used that thinking to put together resources as I found them so I could understand and access the info when I needed it. Now, I did also have some supervisors who were very, very supportive and awesome. It was surprising, actually, to have my boss ask if I was practicing self-care to avoid burnout. I'd never experienced this before working in the corporate world in customer service, so it was really cool. Next slide, please. Thank you. So, what was missing? I did find that in some instances, people weren't sure what to do with a CPS. And at one job, I was told to get a ServSafe credential so that I could work in the kitchen, which I found wasn't a proper use of my skills and, my credentials and what I was supposed to do in the company. I was also asked to monitor men while they submitted testing. I was once told that while participants were in the group, I should go clean the basement. So there were times where we were misused. And, it's definitely something that happens often because employers don't know what to do with the CPS in some instances. I once spent a 2-week period at a desk checking bags and asking people to empty their pockets. So, that's how the CPS was used. And it's unfortunate that it happens that way quite often. I didn't feel like I was doing anything I was taught to do. I wasn't helping anyone at all. And there was no point. Training also was not always made available to us. Also, there were times when the training was available, but we weren't given the time like clinicians were to take off to go and take the trainings. And also, as I mentioned before, just like I ran into positive, supportive supervisors, I also ran into not so great situations. I once had a supervisor who was not in recovery, had never even heard of a CPS, and I didn't understand. It was actually shocking to me that the program director thought this person would be a good fit. Needless to say, she didn't last long, unfortunately, and I hope she's doing well in life, because she was very nice. But the person they hired after that wasn't much better. It was a clinician, and God bless the clinicians, but this one didn't think that CPSs were necessary. So and that's the one that told me to clean that basement. So that's the type of thing you tend to run into in this world as a certified peer specialist. Can I have the next slide, please? Now, even though there was adversity, I followed my nature and made it a point to be the best. I went above and beyond and for my participants because I saw in them what could be me with one bad decision. The ability to bounce back was always, a part of my nature, being ready for change. I just had to use it, and I took advantage of every training opportunity that came my way, even ones that weren't necessarily designed with me in mind. I took a self-guided personal training and motivational interviewing and evidence-based practices. And I studied cognitive behavioral therapy just on my own and learned how effective it was and what it was about. And then I made a point to add new certificates and new credits to my resume or skills list because they were important. I developed an interest in co-occurring disorders and the likelihood a person with untreated mental illness, is likely to use substances and commit crimes and experience homelessness and be in jail. So that fascinated me, and I just started to get my learn on and just know as much as I could. I learned to use my customer service skills to build rapport with my people and my colleagues. And of course, I was able to use my lived experience to better understand and work with people in recovery. Next slide, please. In 2020, due to COVID-19, unfortunately, I was laid off from my place of employment. The heartbreak was quickly swept away by a new job offer at Unity Recovery. The job offer was a supervisor position, and to be honest with you guys, I almost didn't take it. In all my years as a working adult, I had never been in a leadership position, and it was a little bit nerve-wracking. The closest I've been was a team leader at a call center, and that's very far from what I do now. I wasn't feeling sure of myself, but I took the interview anyway, and look what happened. Here I am. I got the job, as you can see, and it's been amazing. It's been interesting, and I've had to develop an entirely new perspective. I've always been the person that prided myself in taking the SOP, reading it, following it, and mastering it, and excelling. And now they want me to make the SOP and to supervise, peers that are following my SOP. It's mind-blowing, and mind-blowing isn't even a strong enough term to describe it. However, I will say that I've been able to use a lot of the skills that I've learned in direct support. Skills like empathy and active listening come in handy when coaching other peers. I do find that I don't have to be anyone other than myself and do as I always do, just treat people with respect as I want to be treated, with understanding and from a place of love and support. My current position allows me to learn a lot of new things. It's a constant learning process, and it's amazing. For the first time, I am managing a project, the Recovery Friendly Workplace Program in Pennsylvania. It's an initiative that we started to teach businesses how to hire, support, and retain people in recovery and seeking recovery. It's an amazing program. I've also implemented employment workshops online where our peer support specialists teach people in recovery job skills, such as interviewing and resume building, so that I can get you prepared to get that job. I provide supervision to peer support specialists who provide these services at no cost to people in recovery everywhere, and it's an amazing place to work. I'm just getting started, guys, but I'm hoping to excel in the position, continue to expand my knowledge, and just continue to move forward. So that's all I got. Thanks for listening, and I'm going to go ahead and pass it along to George.
Thank you, Yvette, and thanks for your witness about the power of making those transitions. That's kind of the nature of what I would refer to as big R recovery. So I appreciate this opportunity and welcome everyone. So I'm George Braucht. I am a clinician with over 40 years experience. Hopefully you won't hold that against me. I am also a person in long-term recovery, and that includes in recovery from a 27-year career with the State Board of Pardons and Paroles. And only half jokingly say that because the challenges around where we work and how we support one another is a key part of what's necessary in order to do this job well. So at some point in my career, I started, well, my background's in community psychology, and it's about how can we kind of move upstream. There's tons of resources for people who are interested in getting into their recovery at that point at which we're, to use a river metaphor, we're rescuing people from drowning, pulling them out of the river. And I thought, well, that's really interesting, but what's perhaps even most interesting is to go downstream and see what those people are doing in 5, 10, 15, 20, 30 years from now. And what I discovered was the power of having folks who have lived experience helping back there at the beginning of the challenge, both in terms of primary prevention, teaching people how to swim, to continue that river metaphor, and also wading into the river and pulling people out who are struggling to keep their head above water. And so this is about who's on first, what's on second, and I don't know's on third. And maybe you remember the Elvis and Costello routine. And really the point of that is, as we get engaged in employment in this field, sometimes it can seem like that routine, because what happens is the frustrations begin to ratchet up. As you ask the question and you get answers that are based on a different approach or different philosophy, it certainly can be challenging. So I really want to talk about 3 elements. What are the core skill, or what's the core skill? And I suggest that's engaging in compassionate conversations for mutually beneficial and mutually challenging relationships. And Yvette's given us great examples of that already. And then what's the core role? And I want to suggest that it's about enhancing, not replacing, acute care with chronic social model peer support services, or what in other words we would call a recovery-oriented systems of care. And then what's the core challenge? And for me, it's always been, how do we sustain connections, both with people and with organizations that are different from us? So just to get into the topic a little bit, I want to suggest that these compassionate conversations are based upon an understanding about how behavior is always a function of interaction between people and environments. The traditional approach is to say, well, it's the P side of that formula that's where the problem is, and we got to fix the people. The problem is in there. And it's about expanding that to recognize the contribution that environments also play to that. And the way to do that is to first learn about with whom you're speaking and explore his or her experience using some key set of skills.
Hello, I'm Mr. Red.
So you may recognize that voice or not. You may think, oh, you've lost your mind. What is that? So there used to be a TV program, and the main character was a talking horse named Mr. Ed. So what do you see there? Well, it's obviously what I would describe as a horsey, or maybe we would call it an Orsie. And the main characteristic of it is pink. So I would call this a pink Orsie, as a way of helping remind myself of this fundamental skill that's necessary, regardless of whether I'm talking with individuals or with organizations and everything in between. And pink simply stands for practice intentionally not knowing, or engage in these conversations with curiosity. And this is a fundamental shift in how we typically do this work. And I'll explain a little more in just a minute. So it fundamentally involves 6 relationship enhancement skills. And you'll recognize these from what today is often referred to as motivational interviewing. They go much further back than MI, but that's okay. Obviously, at the top is practicing intentionally not knowing, which is pink. And then being able to use open-ended questions, and not exclusively open-ended questions, because there's sometimes when closed questions are appropriate. Sometimes you should ask, are you thinking about hurting yourself or somebody else directly? So the idea is to be able to pay attention to what skills are used in interactions. The A stands for affirmations or validations. And this is perhaps the most difficult of the skills, I think, to learn how to use effectively. And then using reflections or paraphrases. And then the S stands for summaries, and then the I is information giving. And that comes last in the process. Often I hear people say, well, we need to go and educate those folks. Well, maybe, but the first task is, do I understand their perspective and their point of view? That's what gets us the quality of relationship that allows us to understand and appreciate, yeah, how we're similar, but perhaps even more importantly, how we're different. So in that process, we're promoting the development of recovery-oriented systems of care. And I want to point out there's an S on that. It's not a system, it's multiple systems. And we're in the midst of a paradigm shift that started 20, 30 years ago, where we're really about enhancing acute care with chronic peer support, and doing that through social model recovery programs. So what does that look like? Well, the traditional behavioral health and physical health model comes from a biopsychosocial approach, where the focus is on the disease and how do we get rid of the disease. It's delivered by disease experts who offer treatment. And it often begins by teaching people what's wrong with you. Contrast that with this relatively new chronic care or social model approach, where the focus is really on recovery, and it's delivered by recovery experts who don't do treatment, they provide service. And it often begins by learning what's right with you and building on those strengths and skills and abilities that the individual has. So the traditional approach expects relapse. The chronic care approach expects recovery or resilience. And I throw resilience in there because in some quarters, the recovery doesn't resonate with people. In most cases, resilience does. So the net effect is we have 150 years of stigma and discrimination that we're trying to battle. And how do we do that from the chronic care or social model approach? Is we promote contagious hope and redemption. And it's about that transition from I was that to now I'm this, and here's where I'm going. That's at the core of the process. And whether you're talking to an individual or to an organization, how we do this is an important part of the process. So you might ask, is it a 6 or is it a 9? Is it the biopsychosocial or acute care model, or is it a recovery model? And the real answer is it's both and. It's both the clinical as well as the recovery support model that gets us where we need to go. Because, you know, the opposite of addiction is, in fact, connections. And it's through those connections that we will begin to change the discrimination that people experience, and reduce, or at least begin to minimize, the stigma that people experience. So these sustained connections are really the challenge. It's kind of easy to step into those parts of our community where we have like-minded individuals. And currently in Georgia, we have actually grown 32, I think is the last count, addiction recovery support centers or recovery community organizations. And it's an intentional process of going in and saying, what's working well here? And that really is the first fundamental question. Once we can identify those assets, then what are the opportunities for improvement? And then really focusing on what keeps us hopeful so that we align on where our objectives overlap. And you can just, this is a graph that shows 4 areas that potentially we want to explore through the strategic planning process to identify who are the allies. And again, this process works whether you're talking about at the individual level, at the organizational level, or at the community level. And it's about how do we widen this tent so that it's not one or the other, but it's both who feel equally comfortable participating. So with that, I will hand it over to Miss Lisa.
Thank you, George.
Oh.
So as Melissa's catching up the slides, and I'm going to share some of the direct work experience that we're doing in Rhode Island at Parent Support Network of Rhode Island, along with many, many partners. And I think just all the things that Yvette and George have shared, I think we try our best to build on all those principles and practices as they have been sharing. Just to share a few of the different ways that we're approaching the work of certified peer recovery specialists statewide. We have a statewide community street outreach team. They are doing amazing work all across the state, and they also work in partnership with other states, other partners in our state in the urban communities and that, but they have not even slowed down or stopped during the COVID time. They have actually become a very essential role. And as peer recovery specialists, they go wherever they're needed, dropping Narcan off at people's doors, doing harm reduction, getting the ability for people to use safely, helping them to be able to get to detox clinics. We transport, we have a crisis assessment center in Rhode Island called BH Link. So a lot of connection and getting folks there and forming the relationships that have allowed us to even get people directly to detox and treatment. And these are important roles because they're doing a lot of community education. So when they're not responding in a rapid way or finding and connecting the folks, they are educating the community through Narcan training, harm reduction, public advocacy. We also have 2 recovery community centers within Parent Support Network, one in Newport County, one in Washington County. And again, the centers are that hub for all that great practice George was describing, and really bringing these new paradigms to life and being able to give, whether it's individual recovery support, lots of different mutual aid groups across many different pathways to recovery. And in our model in Rhode Island, we are integrated mental health and substance use. So we have many peer recovery specialists representing both, along with many folks who are co-occurring like myself. So I bring that lived experience, both understanding from my own mental health and addiction recovery lens. So we are doing a lot of recovery and wellness activities. Like this week, we've got gong baths, we've got yoga, all in addition to the mutual aid, the smart recovery, Dharma recovery, AA, NA, you know, so many. And what I love about it is each day peers themselves say, here's a strength I can offer. I want to help to do this. And they actually become fabric of really operating those recovery community centers. We do training, collaboration, a lot of partnership and public awareness work that I'll talk about a little bit more. But these are community centered, and not only Parent Support Network has recovery centers, but other partners across our state, like George had said, 32 in Georgia. Think of Rhode Island, 45 miles any direction, and yet we still now are getting over 6 recovery community centers. Next slide, please. So we are also working really hard across the state Parent Support Network and other agencies to offer individualized face-to-face peer recovery support services. And with these, we're now moving towards Medicaid reimbursement. So folks are able to get that more intensive peer support. And we all have had that time where we try to help somebody, and it can actually take up to 6 to 8 hours to connect with a person and help them find and navigate and secure different resources, treatment that they need. So with this model, folks are able to bill and medicate and do some intensive face-to-face work. And then we also have the groups, and part of the groups that are Medicaid reimbursable are WAM and RAP. So we're excited as we're building this component. We're just at the brink of getting, our application in, but we do have a handful of agencies in Rhode Island now that are there delivering this face-to-face Medicaid reimbursable service. And I think the one thing I'd like to emphasize is that, just going back to hearing how important Yvette's role was, becoming a supervisor who came up the trenches, boots on the ground, lived experience, so important. And we were able to pass within our Medicaid structure that we can hire supervisors who have lived experience as peer recovery specialists at a non-clinical level and be able to get reimbursed. So I think that's a huge win for Rhode Island, and really looking forward to as we're getting it up and going to the next level. Also recently, we had been awarded through HRSA, an opioid impacted family support program. And this is great because we are able to take the work that we've been doing at a pilot level with our Department of Health, BHDDH, our Department of Children, Youth, and Families, which is child welfare, and being able to really engage and connect with pregnant and parenting women who may have perinatal substance exposure or giving birth to an infant with neonatal abstinence syndrome. We have a huge, it was our dads that, through our peer recovery training and the work that we were doing, that came forward and said, hey, we're dads in recovery. Dads need a voice too. We need to be able to. So now we have this strong Rhode Island Fatherhood Initiative, which is really led by dads that came forward in recovery. And we're working very hand in hand with our Department of Children, Youth, and Families, Department of Corrections, Office of Child Support, both at, at both parental level, both moms, dads, grandparents raising grandchildren, and really bringing this to life with a strong workforce development capacity. Next slide, please. And again, I think many of us within our states are finding that we have to define these roles at a certification level and begin to build some level of competencies. And I'm not going to read through all these. This is the easy part of understanding, where Rhode Island sits with some of this competency work. But I want to emphasize that the work that we're doing is an integrated workforce development training approach. So when we're looking at this through the lens of integration, whether it's mental health, addiction, substance use, physical health, we want to focus across the domains of ethics. Everybody's required to get at least 16 hours of foundational ethics training, and then that repeats itself every 2 years. They have to have at least 6 more hours. We're doing a lot of work around advocacy at an individual and collective level, the mentoring and education, recovery and wellness. Our training really is entry level as we start to look across these areas. But I think the other thing we have found, we're promoting and really working with folks to get trauma-informed training, that we are using the 12 concepts of trauma-informed care, evidence-based seeking safety. We do the motivational interviewing training. So again, that approach to communication and connection is so important. And then deepening that learning through studying even cultural linguistic competence through implicit bias training, national class training. These areas become very important. And now we're getting into a lot of specialty training. If you could go to the next slide, please. Important to this is, the training is good, but nothing beats on the job experience, having the direct experience and practicing. And I say that to folks who go through all our foundational training as they're working on getting their certification. What I have found is that yes, the training is really important and it helps pass the exam that we have to do in Rhode Island, but what's going to give you the real experience to pass is really being able to practice the work. So the more that we can afford those opportunities, and again, volunteerism, incredibly important. I've seen and met people through this work that some want to stay very volunteerism in the sense of not a lot of formalization, but we want to make sure that we're providing that pathway that, you know, the peer recovery specialist role is becoming extremely formalized, especially if we're working on health home teams, to working on, you know, billing Medicaid, having to do all kinds of types of documentation, but also just as important is the volunteerism of the role and not having to get too professionalized in the sense that we don't ever want to lose that. So I could look at like a NAMI organization or our OASIS, the peer recovery specialists there are wanting to keep things at a level that's very consumer or peer driven. They don't want things very formalized. To them, we're working with agencies that things are extremely formalized. We offer a 20-hour week paid internship that we have been able to do to get people to those 500 hours within 24 weeks with real opportunities for placement across the state. We also have our new, through our HRSA grant, each candidate gets a $3,000 scholarship that supports all the training opportunity and even getting a laptop, because in this virtual world right now, without the laptop, they have a hard time doing the work. The $5,000 stipend begins to help them be able to get transportation back and forth to even participate, childcare support. We like moving to the stipend participation because it also reduces cost around tax and being able to, how you have to report those funds versus the minimum wage. So there's strengths in both approaches, but I think most important is for our peer recovery specialists to be successful, to have those on-the-job experiences. And then what we've been able to develop also in Rhode Island is we are working super hard to get those people to the finish line of passing, you know, the exam, getting their 500 hours with all this training, but then we want them gainfully employed, right? And as they're gainfully employed within our workforce, we're giving them ongoing opportunity through our federal registered apprenticeship program to become dual certified, to get specialty training. So we have a peer recovery specialist, community health worker training. They're getting 2,000 hours of on-the-job experience. And then the commitment at that end is an increase of payment within their role. Next slide, please. And what makes this all work, you know, one of the things I said, you know, we've been doing this about 5 years in Rhode Island, and for a period of that time, we held the state contract. Now we've passed that baton, but we're getting much more into specialty training. So on a positive note, we're sustaining and growing all the workforce development work we're doing. And we are a peer recovery council of over 20 agency partners committed to exploring the peer recovery movement, each of us bringing different strengths and taking on the interns or helping to put forward good apprentices. And this includes all our homeless service agencies, our recovery housing network, the hospitals are getting involved, community behavioral health centers with their health home teams and integrated physical health models, our centers of excellence with all our medication-assisted treatment clinics, our federally qualified health centers, and that's where some of the blending between the community health work and the peer recovery specialist work. And then again, you know, very important to that, our organizations like my own Parent Support Network, which is a family-run organization, and NAMI, OASIS, RCOs, all agencies that are family peer-run organizations. And I don't want to lose the heart of that, but all our agency partnerships are important. But I can tell you, I do believe peers should be everywhere, but there is something to be said of growing peer recovery specialists out of real strong peer-run organizations. I hold true to that. And again, we're building a collaboration between all our recovery community centers, and it's actually one of those other recovery community centers that we passed the baton to be able to help do that foundational training. And we're learning that the more we all work together, the stronger our activities and the trainings and special projects, especially like during Recovery Month and the recovery rallies, you're going to see us all working together. We work in partnership at the state policy board. So we have our Governor's Council for Behavioral Health and our Governor's Overdose Intervention Task Force, both of them having many subcommittees and work groups, and us all taking an active participation role. So we, one of them is our recovery work group itself, which just explores our recovery practices and partnership. And again, you're going to see all of representation, not just of the centers, but many of the peer recovery specialists sitting around the table, working hand in hand with state and local officials to make that progress go forward. Another important partnership is working with our health equity zones, especially as we're trying to diversify our peer recovery specialist workforce and ensure equity. So this is a big priority right now for us in Rhode Island, to really diversify the workforce. And again, we're also working with our prevention, our regional prevention coalitions that are, really looking at young children and families from a prevention, right? But they're right alongside us working at the intervention and response and recovery level too. So I just share this, how important what we have learned is that we can be as strong as our collaboration and partnership, but at the heart of that, we need to have strong voice of the peer recovery specialists and the peers who are accessing services and supports and getting involved to really carry that voice forward. So hope these practice examples help to share how we're approaching the work.
Thank you, Lisa.
Turn it back to you, Len. Thank you.
Right. Thank you so much, all three of you. You did a fantastic job. I've got a bunch of questions, and folks, I'm going to start asking those questions. If you have questions, please feel free to put them in the chat box, and I'll add them to mine. And you're more than welcome to join us on the screen. So the first question is really about really the title of this webinar, which is developing the peer workforce. And sometimes it comes down to helping organizations develop as well. And so the first question I have is, how can the presence of peers at an organization actually affect the culture of the workplace? And that for any one of you.
This is Lisa. I guess I'll take a shot at it. I think it's so important that peers feel meaningfully involved in the workplace. Too many, I think it's great in Rhode Island how we have peers everywhere, but it's also very lonely to be one or two peers within an agency trying to make that shift and change. And sometimes they feel bureaucratized, or they can't have a voice, or they don't feel fully engaged or accepted. One of the things we tried to do to help support that is we created a peer-to-peer group soup where those peers can come together on a monthly basis and really self-facilitate themselves as a group to check in what's working, how do they manage those challenges, how can we safely bring what they're learning back to our peer recovery councils so that the agencies can better meet those needs. So I think the collective input and feeling that collective support of peers is extremely important, and that it's not going to help an agency shift if it's just one or two peers. There's got to be a commitment. We also need our champions. Right now, not all supervisors across many agencies are required to be trained to understand. So our peer recovery specialists go through lots of training, but sometimes it's not mandated by our supervisors. And some of them are coming from a very clinical role, as George sort of gave those two paradigms. They're living in the old paradigm, we're living in the new paradigm, and we need to bring all those parties together to get the education to really make that shift. And we need those clinicians and supervisors that are trained to really be the champions for us and help us have a voice to give us credibility.
That's awesome, Lisa. Can I also say, I think having peers in the workforce, it does really make a change in the culture of the company, and it does change the dynamic of people coming in, both participants and other employees. I've been told specifically that, you know, by participants that they feel, you know, extra supported at this specific recovery center because there were peer specialists there who understood them. So it makes a difference, I think, in a couple of different ways. Again, on both ends, from the participants and from fellow employees, because, you know, we make an impact on, I've been told that we've made an impact on clinicians, that they had no idea that, you know, peer support was so awesome and helpful. So it changes a lot of things in the culture of the business. Yes, I think that's correct.
So I would just add that the influence is bidirectional, and the challenge is, how do we celebrate in a way that allows us to recognize the contributions that are actually being made? And if I can put my geek hat on, part of that means being able to quantify improvements that occur in the mission of the organization in terms of outcomes, both processes and outcomes. So in some cases, we've got folks that have gone into hospitals where the staffs were, let's just say, less than enthusiastic about working with that person who has had their 4th, 5th, 6th, 10th overdose. And yet when they're engaged with a peer, suddenly they see this person's no longer coming in. And a year later or so forth, they're actually seeing that individual having made significant progress. On the other side, it really is about being able to show improvements in outcomes. And if we can get together and identify those metrics and track those over time, the stories will make changes in people's views. The data will make changes in where people spend their money.
You know, it makes me think about organizations developing this recovery-oriented culture. And George, you pointed this out, that when the organizations embrace that, they're more likely to help peers to integrate into the workplace. So are there certain elements that we can be looking for that indicate whether a current culture is ready to embrace the integration of peers?
I mean, it's kind of, does the organization recognize they could have more impact and do better? And there's some organizations that will answer negative to that. We're as good as we can possibly be. I don't know, there's a lot of those, but, and so it really is kind of identifying where people want to go and having conversations around how we can help each other get there.
Lisa, Yvette, do you want to?
As I was thinking about that, you know, I know that as we have peers coming through the process and they're going through their interviews to get into their placement for their internship or into the workforce, we're always focused in on their strengths, interests, lived experience, cultural backgrounds. All of that is a part of the decision-making of their journey of where they're gonna go next in the work. So I think, yeah, there's job openings out there and we go to the, you know, the job interviews and all of that. But to me, it's building on the strengths and experiences of the peers themselves, which really adds to the diversity. So if I'm working with peers that have had, you know, they've been incarcerated and now they've done reentry work and they have a story to share with somebody else of how that's the direction they want to go in. Or if I'm working with like my family support folks, you know, they have actually been that mom who was addicted to opioids and got pregnant and then had to move on to the methadone and get the specialty treatment and go through the birthing process. And that, so now they have something to offer back. And it's getting our agency partners to recognize that's the part of the hiring process, and you can take that right to race, ethnicity, you know, socioeconomics, gender, but we bring those lived experiences that make those connections and engagement. And as agencies see that's the culture of experience that we bring, it makes the change and it makes the connections to the participants. I can engage somebody in like 20-minute conversation by sharing my lived experience that would take somebody talking to a therapist over a year. Now, I need to know what to do with that. You know, I can give my good mutual support and connection, but I can also build trust with that person to help them engage back to treatment and services based on my experience.
I'm glad you said that, Lisa, because I find the same thing. Like I can, you know, speak with a participant for 20, 30 minutes and, you know, they tell me so much, and it opens a door, like it opens a massive door when I tell them, hey, listen, me too. You know, I get it. I know what a craving feels like. You know, I know what mental illness feels like. I understand. I may not have your same exact story, but I get it, dude. Like, and, you know, that makes such a difference. And I never would have thought that. And, you know, because before in a different career sector, I never would have thought that somebody understanding would make such a big difference. You know what I mean? And it definitely helps. And I feel good about that working with these people, because I feel like I'm actually doing good work and making an impact and actually helping people live better lives.
Yeah, there's no doubt that the role of the peer specialist in the workforce and in organizations is going to make the organization better, as George indicated that, you know, do you really want to be a better organization? Do you want to do better work? And I'm wondering though, while we know that, there are still organizations that tend to be a little rigid, and they might say, okay, I think it's time for us to hire peers, and then not get any buy-in. And I'm wondering, how do you get an organization to buy in to the concept of peer support and stay true to the values of peer support, not, as Yvette indicated, not learning kitchen skills or things like that?
Well, I know, you know, part of what we've been doing is also incentivizing the agencies. So when I talk about that federal apprenticeship program, the staff are employed, those peer recovery specialists employed, but we have been able to work out through the Department of Labor and Training a small incentive payment to the agency. So it might be the incentive that brought them through the door, but then they have to participate in working on the standards of practice with us, learning those. I think that becomes the change that we see. Also, when we're doing the work at the internship level, we're giving them the opportunity free of charge to have an intern enter into their agency. They're getting free supervision and support for that individual. Training is key. And I think Yvette had said this before, that if you can't get the time out to go to the trainings and the agency isn't invested in the training and letting you, that's where we see the biggest challenge. The agencies that take advantage of the training and technical assist, because that's huge. Like right now that we had been able to have a state contract for 5 years, or having the HRSA money right now, people cannot afford workforce development. So our peers are getting on the job training and being able to receive that. Our agencies need that just as much. Many times the agencies cannot afford the training and the opportunities in the workforce. And I think by offering that opportunity, we're getting their investment, and then we're having discussions together. But it is hard to get agencies to see the value. The more we can go back to sharing the data and the stories and collecting that, you know, being able to show. I can remember especially in child welfare. DC YF workers were saying, what, we're gonna hire and work in partnership with the people that we were just helping and supporting? And I never thought that we'd get to a place that DCYF Child Welfare was helping us to approve family leaders who had previous experience in child welfare and had overcome those backgrounds. And now we get specialized focus of getting those individuals approved so that they can engage and help the families through this process. And the outcome of that has been, we have been the rapid response team at an investigative level, helping many families, over 150 this year alone, not open up to DCYF child welfare. And though all of those families were struggling with opioid addiction.
Nice. We have a question in the chat box from Kathy Whalen. Are there any peer recovery national websites that could direct those who are looking to become certified in their state to find either free training opportunities or to get information on state scholarship programs which would supplement their ability to participate in trainings that they need help in paying for?
Well, there is, depends on which domain you want to go into. And part of the challenge here with this workforce development emphasis, our field is at least bifurcated, if not trifurcated. So at the federal level, you've got alcohol and other drugs, and you've got mental health. And those two don't necessarily play well together. So at the peer level, you've got that same sort of initial difference. And so a certified peer specialist may be a person who has lived experience in mental health recovery or in substance use recovery. So that's kind of a long way of saying there's not a national organization. There is, for example, the International Association of Peer Support or Peer Support Services, INAPS.
Yep.
And certainly that's more leaning towards the behavioral health side. And then you've got other organizations that will offer those credentials, in some cases in family services. And so it's kind of up to you to figure out what's available in your state and to pursue those at that level.
Yeah, I haven't seen one national place that really highlights where each state is and what they're offering trainings, but I think that would be a great resource, especially if there's supplement, because I know, like I said, most people, if we weren't offering it free with the incentives and supports, they'd have a hard time getting it realized and be gainfully employed.
Now, I will say there is a new Addiction Technology Transfer Center that is focused specifically on peer services. I wouldn't describe that as an umbrella organization where you learn how to become certified.
Well, no, I haven't seen anything on a national level. As George and Lisa stated, only statewide. I know, in Pennsylvania per se, you can go to the Pennsylvania Certification Board and find information on becoming a peer specialist, where to get the certification, and some actual continuing education credits and where you can find those. And I'm sure, and I don't even believe that in every state, the peer specialist is looked at as something that is certified under like a certification board. So, that's going to be something that you're not going to find in some states because of that. Yeah, it's interesting to see, and that would be something that I would like to see across the country. Like, whatever state I'm in, can I become a peer specialist, and how do I do it?
Good point. Not every state has certified peer support specialists at this time. I think that we're down to our handful, though, that, we just picked off California, so that's a good thing.
I think the financial supports are so important, Len, because I can say like last year alone, we trained over 200 people, but we only had enough paid internship opportunities for about 30. And fortunate, the agencies are starting to see we couldn't carry it alone. And now some of our partner agencies are paying for those internships too. But the need and the training can't come, the training ability is not coming close to the support to get to the employment.
Good point. As the field becomes more mature, we're seeing more and more peers entering the workforce as peer specialists. And along with that, we are beginning to develop sort of the practice of supervising peers. And, there's a school of thought that peers should be supervised by other peers. But most oftentimes, peers are supervised by clinicians who are not, or tend not to be anyway, people in recovery. So what are some pros and cons of promoting or hiring peers into supervisory roles versus the idea of having clinicians supervising peers?
Yeah, I think it's a big difference. And I'm only speaking from experience as someone was a peer specialist and now is a peer supervisor. It's helpful that I've actually been in the role that the people I'm supervising are in currently, which, as I mentioned before, as I stated, during the presentation, that there were times where I was supervised by people who didn't know what a CPS was, wasn't in recovery, and it was mind-boggling. Like how can I come to you for help, or what if I need support, and my participant said this, what can I do? Like you don't know, just so it didn't make any sense. But I think in hindsight, if I had had supervisors, the one supervisor I did have that was a peer was amazing. So that's what I can say from my standpoint, is that I've seen both ends of the stick, and that when I did have a peer as a supervisor, it was phenomenal. It made a difference. I was asked on a regular basis about my self-care. He understood caretaker burnout that we deal with as CPSs, and he got it. He let me talk about my participants at length if I needed to, and gave me my supervision on a regular basis, like it should be done. So, there are pros to having a peer as a supervisor. Absolutely.
And I'd say in Rhode Island, we have 6 lived experience certified peer recovery specialist supervisors in our organization now. I think definitely helps build mutuality and a good reflective supervision model, because it's almost like the concentric circles, right? So in our organization, because we're family and peer run, we have the ability to support one another and be that peer support to each other. And we're learning through that experience then how that filters out and helps all the peers we're each working with. But we do have within Parent Support Network one employee who is our clinical director. She is a LIM licensed mental health clinician, and she's also an advanced LCDP and has her CAGs and stuff. And we changed her world because we're so used to peers, that one peer going into the agencies with all these clinicals, and instead we reversed it. And the first year it was touch and go and building that, but now, she focuses in on making sure that the clinical needs of the families and individuals that we're helping or supporting are getting to the right levels of care, and plays a role of more quality assurance. She doesn't do any direct service delivery. She helps look out for our self-care and are connecting us to our employee assistance programs as needed. She's a great partner and champion for bringing that voice. So we flipped it. We flipped it at Parent Support Network, and I think it's working well. It does give us a level of credibility on our projects and our partnerships to have such a strong clinical leader. But it was a huge learning curve for her to find her place in our organization, and because you're not used to seeing that. You're used to seeing the reverse.
Right.
So I hope that helps.
I'm glad you got someone who was willing to take that learning curve. You know what I'm saying? Because you got people who are staunchly against peer support being a thing. And that's the one that I ran into that wasn't a CPS or in recovery. It would have been nice if she was willing to learn and if she was open to being that person that wasn't understanding of all and to take some advice from us and to understand what we do. But she wasn't. So, you're lucky to have found someone who was actually open and willing to do that.
Yeah, and one of our policies in our supervisory model is, in most cases, she never supervised alone. So we have a co-supervision model where we match the lived experienced supervisor who's supervising day to day with her, and then she comes in twice a month to do a nice connection with the so it's not where she's doing traditional clinical supervision.
So I'll just make a distinction between administrative supervision and what I prefer to call performance support. And that to me is the fundamental distinction between how a professional supervisor has a role, because you do have to learn how you operate within that organizational context. But performance support is, how do I have a place where I can cuss and celebrate equally well? And that's different than clinical supervision. So the self-directed nature of professional development for a peer is just vital to having that sense of, I'm really getting better at what I do. And to me, that's one of the biggest challenges. As part of the CARES Academy, the last day we do an inoculation where we say, you've been here a week and you've had a great time and your mind has changed about a lot of things, but the world out there hasn't. So what are you going to say when the person comes up to you back home and says something like, yeah, that peer recovery support stuff isn't going to work here? And it's amazing how quickly people revert back to, it will work, and here's how we go, this is how we're going to do it. It's about learning how to lean into that, and I liken it to the difference between paying attention to the words of a song versus the melody. Can you lean into it and understand what's behind the concern? And so for the peer recovery support service provider, it's not about transference and countertransference, which is the clinical model. It's more about what are you doing well and what you want to get better at. And that's a different frame of reference.
Well, thank you. Thank you very much. Melissa, if we could bring up the PowerPoint. Just wanted to give folks an opportunity to take a look at some of the resources. We've got the Philadelphia Peer Support Toolkit, which is fantastic, very easy to use. Recovery-friendly workplace, the New Hampshire checklist, the recovery-friendly workplace places, the PA, and the Recovery Live event that we had last month, which is cultivating resilience and supporting recovery at work. I want to thank our panelists today for joining us. Fantastic job, you guys. I'm hoping that everybody got a tremendous amount out of this topic, as much as I did. And I'd like to have you join us next month for the final fall recovery webinar, which is on Tuesday, December 8th at 2 to 3:15. It is on reimbursement for peer support services through Medicaid with presenters Judy Fox, Anita Bradley, and Denise Holden, and our very own Stephen Samra will be moderating. Again, thank you to our speakers and all of you for giving us the time today. We know it's valuable. We know that there's just so many things going on, and for you to give up an hour and 15 minutes to us is really nice. And we hope you make good use of the information you got today, and have a fabulous Veterans Day, and we will see you next month. Bye-bye, everybody.